heart failure, evidence, evolution, and emerging therapies. When given the task, the topic was kind of updates in heart failure, which can cover a lot of different things. And I felt for the purposes of kind of the scope of a 45 minute to 1 hour talk, I was kind of focusing more on pharmacotherapy. I think perhaps a separate discussion can be for more device-based therapies, although I have a little bit of that here that is kind of sprinkled in. All right, I have no financial disclosures, and everything I'm going to be talking about is FDA approved here. So the objectives of today's talk are to understand the four major pillars of heart failure guideline-directed medical therapy and the push for early and rapid sequence escalation. Recognize the role for adjunct medical therapies in the treatment of heart failure with reduced ejection fraction. Appreciate the value of complete in-hospital diuresis before hospital discharge. Acknowledge the role for implantable PA pressure sensors and the benefits of hemodynamic guided diuresis, and realize the need for maintenance therapy in heart failure with reduced ejection fraction long term. Um, Start off with just a case here, and I think that myself as a heart failure cardiologist, but as well as a hospitalist, will often encounter this as a consultation from our surgical counterparts. So 65-year-old male, former smoker, type 2 diabetes with kind of a moderately elevated hemoglobin A1C, hypertension, hyperlipidemia, some CKD, comes into the hospital with chest pain, diagnosed NSTEMI, found to have multivessel coronary disease, kind of a moderate to severely reduced ejection fraction, severe mitral regurgitation. He comes in to telemetry unit on the surgical service and undergoes surgical revascularization. Fortunately, uncomplicated post-operative course, had an Impella 5.5 at the time of the surgery, was decannulated without issue, and post-operatively was transferred back to 5 East and recovering, and you get a call for consultation for quote unquote like medication optimization. So very kind of common situation that we encounter here. And in this case, a patient has some chronic kidney disease, their potassium is okay. And in terms of their vital signs, a little bit of an elevated resting heart rate, some blood pressure to work with, not the most robust. So already you're kind of thinking how you're going to sneak on some of these really impactful guideline-directed medical therapies and see how you might be able to get them all on board safely with close attention to the patient's vital signs and their end organ function, particularly their kidneys. The Fantastic Four, like the four pillars of heart failure therapy, many people already are familiar. Modern day four pillar therapy in heart failure with reduced ejection fraction includes ARNI, beta blocker, mineralocorticoid receptor antagonists, and the most recent addition, the SGLT2 inhibitor. And for us to kind of understand, like, what is that there's a gap, right? Like everybody recognizes, I think in this group, but maybe not universally, that these therapies should be instituted. But what is actually going on? So in the trial of the CHAMP registry, they observed outpatients who have heart failure with reduced ejection fraction to see what the real life practice patterns are with respect to the introduction of these four pillar medical therapy. And you can see here at the top, a lot of people are not on optimal medical therapy. And so kind of broken down each column by class of medication, with the green bar being those that are treated. Mostly less than 50% of patients are receiving a lot of these guideline-directed medical therapies in practice. So there is a gap here for whatever reason. So despite everything that we know about the efficacy of these therapies, and then of the patients that were put on these four pillar therapies, the vast majority of them are not at target doses. So of the eligible patients, only 27% were prescribed, or sorry, 17% were prescribed ACE or ARB at target dose. Only 14% here, I don't know if you see my cursor, in the middle pie chart were prescribed ARNI at optimal dose. And beta blockers, 27%. Mineralocorticoid receptor antagonist is more widely used. It's actually like 76%. And of everybody, only 1% of eligible patients were receiving target doses of all medication classes simultaneously. So it's something that we all know about and we want to do, but for some reason in practice, it just doesn't happen. On the outpatient basis, the patients are not um, put on this robust evidence-based quadruple therapy. Why though? So my goal in this presentation is to convince you of the great value of these therapies if you're not already convinced, and the real triumph that they represent in the treatment of this disease that we commonly encounter, both myself as a cardiologist, but also hospitalists and internists on an outpatient basis. And these medications really do need to get on board. They have really significant impact on survival in a population that carries a very high risk of morbidity and mortality. So um, for the longest time, I'd say, I think going back to like the 60s or so, we kind of realized this theory that heart failure is a neurohormonal mediated disease process that actually has kind of negative feedback on itself through the normal hormonal pathways that are appropriate responses initially, but ultimately have detrimental effects on the heart. So in patients with heart failure, there is activation of the sympathetic nervous system. What does that mean? Alpha 1, beta 1, beta 2 receptor stimulation, increased heart rate, increased contractility, RAS activation, increased vasopressin. So what is initially an appropriate adaptive response actually has maladaptive effects on the heart by increasing vasoconstriction, increasing myocardial oxygen demand that ultimately results in progressive cardiac dysfunction. So one of the earliest therapies, I will not say the earliest, one of the earliest therapies was beta blockers to step in here and put a halt to the sympathetic nervous stimulation. And beta blockers is old news, right? Like we know about beta blockers forever, and they've been saving lives in heart failure for decades. And it's been shown time and time again that beta blockers are efficacious in the treatment of heart failure in different populations. In the CIBIS trial and MERIT trial, and kind of less sick patients, in Copernicus trial with carvedilol in sicker patients, and then in the Capricorn trial, which is not shown here in this table, but in patients with a history of MI. So beta blockers work broadly and kind of uniformly across different phenotypes or different populations of heart failure, both ischemic and non-ischemic. So therefore, evidence-based beta blockers, carvedilol, sustained release metoprolol, bisoprolol, have garnered a class 1 recommendation in the management of heart failure because of really the significant impact on survival that you achieve with the simple introduction of a beta blocker. Just one thing of note here with beta blockers, and while I'm kind of harping on the point of getting people on medical therapy quickly and rapid escalation, beta blockers is one of those medications that you want to maybe take it a little bit more slowly. So we're not thinking about kind of rapid escalation during one short hospital stay necessarily. It's something that you might titrate or dose escalate every 1 to 2 weeks. The reason being is, yes, it's helpful in the kind of the neurohormonal blockade here in the sympathetic nervous system, but it has negative inotropic effects in theory. So in somebody living with chronic heart failure, maybe with a recent decompensation for acute heart failure, you don't want to rapidly escalate a negative inotrope in that population. So you get it going and you take it slow every 1 to 2 weeks. So next, we'll shift our attention to the renin-angiotensin-aldosterone system, or the RAS system. Again, initially beneficial, however, ultimately maladaptive. So in somebody living with heart failure, low cardiac output, poor renal perfusion, results in RAS system activation. And what does that result in? Increased blood pressure, increased aldosterone, hypertrophy, and fibrosis. So the development of RAS blockade initially with ACE inhibitors and angiotensin receptor blockers was really a key change in the trajectory of our heart failure population. With the earliest study here being the consensus trial back before I was even born. I was born in 1988, so this is 1987. So tried and true. Enalapril versus placebo resulted in a 40% reduction in heart failure and hospitalization and mortality. So really an impressive impact with the simple introduction of an ACE inhibitor. And we see it again repeatedly in different trials. The consensus trial being like a sicker population, the SOLVE trial being a less sick population, the SAVE trial showing once again ACE inhibitors being effective in a post-MI population. So all with significant mortality reduction. And a similar trend is seen with angiotensin receptor blockers or inhibitors, but maybe like with a little bit less compelling results. So when studied head to head against ACE inhibitors, no significant difference. And it's like, okay, well, that's good. Like, I have an alternative option here. But what kind of makes you perhaps have a little bit less confidence in angiotensin receptor blockers is in subsequent trials, like the VALHEF trial, where it was actually an angiotensin receptor blocker against placebo. It showed no reduction in mortality. There was a reduction in heart failure hospitalization, but you went from a 40% mortality reduction with enalapril in the consensus trial to no mortality benefit with Valheft or valsartan. So kind of the takeaway here is, and guidelines reflect that, is that ACE inhibitor is really kind of preferred. There's more robust evidence for ACE inhibitor over ARB. I think that oftentimes in practice, we kind of see them as interchangeable or equivalent. But really the data is more robust for ACE inhibitor. And ARB is a fine alternative, particularly in patients that are intolerant to ACE inhibitors, maybe from chronic cough or angioedema. But your mind should initially kind of go towards ACE inhibitor when you're kind of thinking about those two options specifically. But with time, there's improvement, right? So initially, our toolkit had ACE and ARB, but now flash forward to about 2014, and kind of leading up to that, there was recognition of an alternative pathway here, the neprilysin pathway. So natriuretic peptides are a good thing, unlike other neurohormonal systems that I've been kind of talking about with beta blockers and the RAS system, which have maladaptive effects. All of the effects of natriuretic peptides are actually good. And there were attempts to make kind of recombinant natriuretic peptide, i.e. nisiretide, to kind of replace a deficit perhaps of natriuretic peptides. But the outcomes with nisiretide did not show any sustained benefit. Like, yes, they work, but they're a continuous IV medication. And maybe the reason that they don't have lasting mortality or survival benefit is because it is short acting. And once it's turned off, the effect is waned. So how can we perhaps increase our own endogenous natriuretic peptides? Well, one way would be to prevent the degradation of them. So neprilysin is an enzyme that breaks down our natriuretic peptides into inactive fragments. So if we block neprilysin, then we kind of boost or maintain our own endogenous natriuretic peptides. And what does that afford us? a decrease in blood pressure, a decrease in sympathetic tone, decrease in vasopressin, hypertrophy, fibrosis, and actually an increase in natriuresis and diuresis, all good things. Um, the angiotensin receptor neprilysin inhibitors, as it is actually a combination of a neprilysin inhibitor and an angiotensin receptor blocker. Why an angiotensin receptor blocker? Well, by virtue of blocking neprilysin, it actually increases angiotensin 2 levels as well, which can cause vasoconstriction, and we don't want that. So, angiotensin receptor blocker serves the purpose of kind of counteracting that one detrimental effect of up regulation of our own endogenous peptides. And why not an ACE inhibitor? Why didn't they make it like a neprilysin plus enalapril? Kind of because of the bradykinin pathway consideration that the neprilysin inhibitor will increase bradykinin. And if you add also an ACE inhibitor, your risk of angioedema increases exponentially. So not a good partner for our sacubitril friend. Um, so, so the Paradigm HF trial, out with the old, in with the new, was a landmark trial, double-blind, randomized controlled trial, 8,400 patients with heart failure with reduced ejection fraction below 40%, with New York Heart Association class 2 to 4 symptoms, on guideline directed medical therapy of the time, and were randomized to receive either ARNI, or ACE inhibitor, enalapril. So it really was competing head to head against its predecessor. And the results were so compelling that the study was actually stopped prematurely after 27 months due to overwhelming benefit of ARNI. It reduced the primary composite endpoint of cardiovascular death and heart failure hospitalization by 20% relative to enalapril, with a number needed to treat of just 21 patients over a 27-month span. So it really established sacubitril valsartan, or Entresto as we know it, as the cornerstone therapy for heart failure, and led to strong guideline recommendation to actually be preferred strongly over ACE inhibitors, and kind of definitely over ARB alone. And one thing of note, symptomatic hypotension is a little bit more common with Entresto compared to just ACE inhibitor, although not necessarily associated with worsening renal function per se. So the guidelines here reflect that priority of ARNI. So class 1 recommendation for ARNI in the treatment of HFrEF with New York Heart Association class 2. I'm sorry, 2 to 3. And in folks that are not candidates for ARNI, cannot tolerate ARNI, maybe due to that symptomatic hypotension consideration, then ACE inhibitor would kind of be your next order of operation. And if ACE inhibitor is not tolerated, perhaps due to cough or angioedema, then ARB is kind of your third line option. They all technically, yes, have a class 1 indication because in some studies or another, they've demonstrated a survival benefit, which is significant. But if we had to kind of offer order of operation, ARNI is definitely your best bang for your buck. And also financially, like high value medication, and then ACE, then ARB. Lastly, to round out the discussion of kind of the RAS system, is our aldosterone antagonist friends, which were developed and similarly on numerous occasions proven to be efficacious with significant reduction in mortality, with similarly trials that go back several decades. But the adoption of this drug, spironolactone, eplerenone, was associated with an increased risk of hospitalizations for hyperkalemia. So therefore, it's kind of like a cautionary tale. So there's a significant survival advantage with being on mineralocorticoid receptor antagonists, but don't just read the headline. Don't just read the guideline and see that it says it's class one. You got to pay attention and make sure it's an appropriate recommendation for your patient at hand. Make sure that their potassium is of an appropriate level and that their eGFR, renal function, is appropriate for consideration of a mineralocorticoid receptor antagonist. So we're talking a potassium level below 5.0 and eGFR at least above 30 milliliters per minute. It's not to say that I will absolutely exclude patients that are kind of saddling the borderline there from consideration of the therapy, because with all these drugs, again, I want to afford my patients the significant mortality benefit of these drugs, but it needs to be done carefully. And if you have a patient that's kind of a marginal candidate, then you definitely got to pay close attention and make sure that they're tolerating it from electrolyte and end organ renal function standpoint with close laboratory to follow. So the guidelines again here reflect a class one indication for mineralocorticoid receptor antagonists to in the reduction of heart failure, morbidity, mortality. One interesting anecdote, and this is actually a patient I had yesterday, I just want to share, and maybe something that you might encounter in the perhaps inpatient setting for people that have a continuation of testosterone replacement therapy, probably more so in the ambulatory setting. But I have a patient who is very fixated on his testosterone replacement therapy. His levels are therapeutic, but spironolactone will impact that sex hormone pathway. So folks that may be on testosterone therapy for one reason or another, you may actually think about eplerenone as a surrogate there, because it is a more direct and specific mineralocorticoid receptor antagonist, and less so of kind of a more broad aldosterone receptor. So, yeah, just a little tidbit there that was inspired by an encounter yesterday. And then careful monitoring of potassium and renal function. So let's pause for a moment and kind of talk about potassium. So like I mentioned, there is an association with clinically significant hyperkalemia with mineralocorticoid receptor antagonists, albeit low in overall frequency, but there is an uptick. And therefore can sometimes limit the successful introduction or give people lack of confidence in initiating mineralocorticoid receptor antagonists. So, and particularly because these trials that were done perhaps reflect maybe like a healthier population than what we see in real life practice with people that, in particular here at Keck, which have a higher comorbidity burden. And therefore, like the safety of a mineralocorticoid receptor antagonist may be overstated based on clinical trials alone. So, careful attention to it is appropriate. So, in the Swedish heart failure registry, analyzed over 11,000 patients with heart failure and showed only about 40% of patients eligible for mineralocorticoid receptor antagonists received a therapy. And interestingly, the most significant factor associated with non-use of these drugs was actually their creatinine clearance and not hyperkalemia necessarily. And also interestingly, people were, or providers were withholding the therapy for GFRs in the 30 to 60 range, which are technically not a contraindication to the introduction of mineralocorticoid receptor antagonists. So a little bit of like excessive caution with regards to renal safety has been kind of proven to result in underutilization. So, really maybe pay more attention to their potassium levels, maybe a little bit less so to their creatinine clearance, particularly if they're above that 30%, or sorry, 30 milliliter per minute threshold. Um, but one medication here, kind of novel therapy, was investigated in the Diamond trial, which was an investigation of patiromer, a novel enteric potassium binder, and the impact of this on RAS inhibition tolerance. So this was a randomized placebo-controlled trial with a run-in phase that was by design in which patients were given patiromer while already kind of proving their ability to tolerate RAS inhibition. And once the RAS inhibition therapy was optimized to target dose, either ideally more than 50% of the recommended dose for ACE inhibitors, ARB or ARNI, and 50 milligrams of mineralocorticoid receptor antagonists, patients were then randomized 1-to-1 to receive patiromer or placebo. And the primary endpoint here shows that patiromer significantly reduced serum potassium levels. You can see here there are fewer hyperkalemia associated events, lower need for mineralocorticoid receptor antagonist dose reduction or withdrawal, and then also an increase in total RAS inhibition use with ACE inhibitors, ARB and ARNI. So an effective drug, and the reason it's not maybe more commonly encountered here in the US at this point in time is that the guidelines, which were published in 2022, uh, um, preceded um, the most recent clinical trial, the Diamond trial. So it currently only has like a 2B indication, but it may garner more support in the future with kind of later iterations of um, of the guidelines. Because again, this Diamond trial, which had kind of the most impressive results of patiromer, wasn't the first study of patiromer necessarily, but the most impressive outcomes followed the publication of the 2022 guidelines. So I'll digress a little bit and a little bit of a kind of a jog everyone's memory, a history lesson here. So I want to give a shout out to rosiglitazone. So rosiglitazone, thiazidine was used initially as a treatment for type 2 diabetes, but in 2007, I think many of us remember rosiglitazone garnered a negative spotlight after a landmark meta-analysis identified a 43% increased risk of MI for patients treated with diabetes in this drug. Also increased risk of heart failure de novo and heart failure hospitalization. So the medication was immediately removed from the European market, and in the US, unfortunately, gave rosiglitazone a black box warning. Um, so what's kind of the impact of this meta-analysis, which kind of put rosiglitazone in a negative spotlight? The impact is that the FDA now required cardiovascular outcome safety trials for all medications used in the treatment of diabetes. So thanks to that, when the SGLT2 inhibitors were being developed, it required the attention of cardiovascular safety trials. So um, uh, SGLT2 inhibitors being used in the treatment of type 2 diabetes, but also having kind of pleiotropic effects with cardioprotective, nephroprotective effects, reduction in inflammation, reduction in oxidative stress, fibrosis, decreasing intraglomerular hypertension, and sympathetic nervous system activation, all kind of protective of kidneys and increasing myocardial efficiency. So this requirement for safety trials was borne out in the EMPA-REG and CANVAS trials, but also repeatedly with other medications of the same class. First empagliflozin, canagliflozin, dapagliflozin, or tugliflozin, sitagliflozin, and time again in patients with diabetes with cardiovascular risk factors or established cardiovascular disease, SGLT2 inhibitors were shown to have a significant improvement in cardiovascular death and heart failure hospitalizations. So and kind of beg the question then, well, if it is effective in reducing cardiovascular risk in diabetics, like maybe it will be helpful in achieving the same outcome in non-diabetics. Um, so here we see the first kind of iteration of that with empagliflozin versus placebo in a non-diabetic population. Here demonstrating a significant reduction in the primary outcome, cardiovascular death and heart failure hospitalization. And once again, um, with dapagliflozin showing a similar outcome here. Um, so both studies showed nearly like a 25% reduction in the composite endpoint in cardiovascular death and heart failure hospitalization. So really an impressive benefit that you garner from introducing SGLT2 inhibitors, and therefore has gained SGLT2 inhibitors a class 1 recommendation in the treatment of heart failure that it really deserves, irrespective of diabetes status. Um, so a few just notes here, and this is again just the kind of the figure ones from both the DAPA-HF and EMPEROR reduced trials. But a few notes here regarding the use of SGLT2 inhibitors. Obviously, you'll want to hold it in the setting of DKA, critical illness, severe hypotension. Not that the medication itself is particularly hypotension inducing, but perhaps like the natriuresis may contribute to further hypotension theoretically. Although in practice, I don't see oftentimes like a significant increase in urine output just from SGLT2 inhibitors alone. Um, and then also paying close attention to renal function. Patients with EGFR less than 30 really should not be on SGLT2 inhibitors, and definitely not patients that are end-stage renal disease. And then one last thing with SGLT2 is it needs to be held preoperatively. I think by guideline or by pharmaceutical companies just the day before, or if there's any prolonged NPO, although what we commonly see here is that surgical teams will want us to hold it for several days, or maybe up to like 5 days, 7 days before, and that's fine, whatever needs to get done to help the patient along. So, but again, it's a medication that is so well tolerated with very little side effect profile, and again, really insignificant hypotension or really negligible. So, in honesty, like if you're wondering whether or not you should be starting a patient with HFrEF on SGLT2 inhibitor and they're not end stage renal and their GFR is above 30, the answer is yes. And it's like, why haven't we already done it, kind of thing. So if they have a pulse and their GFR is above 30, probably start them on SGLT2 inhibitor. And here's just kind of the guidelines reflecting the class 1 indication. So there we kind of have it. We've covered the 4 core therapies of heart failure. And it's abundantly clear why we feel so strongly about these medications. Many of them have stood the test of time, and their impact on mortality is individually each impressive. But if you look here at the bottom, this is the overall cumulative impact of quadruple therapy. There's a 73% relative risk reduction in all-cause mortality, and an estimated 2-year mortality reduction from 35% to 10%. It's like really impressive numbers here. So getting people on this quadruple therapy is no joke, and you're really saving lives. We're not like in the OR doing very dramatic surgeries on people, and pharmacology is not as sexy, but these medications are really, really impactful, and will really change people's trajectory for the better. And um, so, sorry, let me just uh, oh, so yes. So and while we haven't been able to kind of study quadruple therapy in any like randomized format, there was an interesting cross-trial analysis here that incorporated the three landmark studies of mineralocorticoid receptor antagonists, ARNI, and SGLT2 inhibitor, and compared it to historical convention, which was just ACE inhibitor slash ARB and beta blocker, and to show kind of the aggregate effects or aggregate benefits of combination multi-drug regimen. And they estimated that comprehensive medical therapy here, quadruple therapy, compared to just uh, the conventional therapy, helped people achieve an overall survival here on the y-axis of a 6.3% difference in survival across kind of all age groups. So really a huge impact on survival here when you follow these people long term on quadruple therapy versus just conventional therapy alone. So the original Paradigm HF trial, which was our ARNI trial, established the superiority of ARNI over ACE, but it excluded patients that were acutely hospitalized. It was an outpatient study. So the subsequent Pioneer HF trial, also looking at ARNI, actually looked at that inpatient hospitalized cohort, and exploratory analysis of this revealed that significant reduction in that primary endpoint by 8 weeks. So you might ask yourself, like, well, how long do these people need to be on these drugs to derive the benefit? It's early and and the impact is significant. So you're already seeing by 8 weeks, 56 days here, a survival difference or a reduction rather in the composite endpoints of heart failure hospitalization and death with a difference of like nearly 7%. And similarly, a secondary analysis of the DAPA-HF trial for dapagliflozin in our non-diabetic patients showed that the rapid introduction of SGLT2 inhibitors yielded benefits by 28 days with a significant reduction in the hazard ratio. So taken together, these medications not only have like tremendous impact, but they're quick in onset. So, I have the title here, Carpe GDMTM, or seize the day and start GDMT without delay for patients, because it really saves lives and it saves lives quickly. So to further kind of look into the need for timely introduction of GDMT, the STRONG HF trial was designed, which was a randomized trial that demonstrated the safety and efficacy of rapid uptitration of GDMT with close follow-up in after acute heart failure hospitalization. So patients were randomized 1-to-1 to either high intensity care or usual care in terms of their GDMT escalation. And the high intensity care group um, um, were started on medication therapy and increased to 50% of target doses before discharge, and were instructed to be on 100% of target doses within 2 weeks after hospital discharge, with close follow-up at 1, 2, 3, and 6 weeks. And again, the outcomes of this were impressive, and the study was stopped early because of the greater than expected difference between the two groups. The primary endpoint at 180 days, heart failure readmission or all-cause death occurred significantly fewer patients or less frequently in the high intensity care group, with an adjusted difference of like 8.1%. And in the high intensity care group by 90 days, significantly more patients in the high intensity arm were successfully up titrated to full dose of all these four pillars of therapy that you kind of see here in the middle pair of columns. The kind of orange red bars being the high intensity group, and kind of the bluish bars being the usual care group. And you'll see a significant higher fraction of maximal tolerated dose in the high intensity group across all three drug classes. Also of note, there were similar incidences of serious adverse events between the high intensity group or the usual care group. So rapidly escalating therapy does not necessarily mean you're putting the patient at higher risk of serious adverse events or fatal events for that matter. Um, so important to get people on therapy early and up titrate quickly without delay. What I often see happens is people may get on kind of wimpy doses of therapy by the time they're discharged, and then it just kind of lingers there for a long time. And it's really a disservice to patients because, again, by early rapid escalation, we see that significant divergence in survival by 6 months, by 180 days. So in terms of like how you might approach this, and this is just stylistically how I might do it. I before discharge from the hospital, I will strive to get people on at the very least all four pillars of therapy. Um, and you don't need to start one at a time. Like I kind of think about combination initiation at first, just with careful attention to their renal function and blood pressure. So perhaps one day I'll start them on an SGLT2 inhibitor and Entresto. Maybe the next day I start them on a metoprolol, and then the next day spironolactone in the hospital. And maybe I offset their metoprolol for morning and then their spironolactone in the evening so that they don't have like stacking effect of all their medication. And then, with the heart failure, again, with the guidelines, we're trying to have close follow-up with all of our heart failure patients post-discharge. So at that visit, that's an opportunity to escalate things further. So I might increase their ARNI dose and their beta blocker dose to target a resting heart rate below 70 with respect to the beta blocker. And I'll try to escalate the ARNI to goal dose, which is the dose is demonstrated to be efficacious in clinical trial, which was that 9,703 BID dose. And hopefully within a matter of a few weeks, and I know this is not as quickly as was performed in the strong HF trial, but by incorporating this into your practice, you can reasonably get people on four pillar therapy within maybe 6 to 8 weeks or so. So like when they see you in 1 to 2 months, and oftentimes I will partner with my APPs and piggyback off one another to more frequent visits to get people on these four pillar therapies before they see me kind of for follow up. And that way, it's the most effective use of the patient's time, and we're getting them the benefits of these medications that they deserve quickly. So what else? What else do we got? We kind of talked about the four pillars of therapy, and we talked a little bit about the novel potassium binders, but there's other stuff out there that I'm sure you guys have all heard about. Um, and if we look at pharmacotherapy, or kind of the chronology of pharmacotherapy in clinical trials over the last 5 decades, like our toolkit is growing nonstop. And it's actually becoming kind of an issue of polypharmacy, right? Like yes, we have all these drugs nowadays, but it really has to be a good kind of value for the patient and a good added benefit to the patient. I would not want patients to be burdened more than they already are with just more meds just because there's some weak data to support perhaps a slight symptom improvement, but no mortality benefit. You're trying to kind of got to give consideration like how much bang for your buck or how much juice are you squeezing with every additional medication you're adding on board for these patients that are often already kind of bombarded. So in the 1980s, after we spoke about ACE inhibitors were developed, the hot topic was afterload reduction. So sorry, this was supposed to pop in here. But the VHEFT-1 trial, which was hydralazine and combination isosorbide dinitrate, was compared head to head with not just placebo, but prazosin, which is kind of funny. And obviously, prazosin didn't work because we never heard about prazosin again in heart failure. But hydralazine isosorbide dinitrate did win compared to placebo with a significant improvement in ejection fraction, exercise tolerance, and survival. Unfortunately, hydralazine isosorbide dinitrate didn't really stand up the test of time in VHEF2, which was kind of version 2.0, where our reigning champion, hydralazine isosorbate dinitrate, now faced a new challenger, enalapril. And this time, hydralazine isosorbate dinitrate failed to impress against its rival, enalapril, which, like we spoke about, was developed in the late 80s. So this study actually anchored ACE inhibitors as a core heart failure therapy for the longest time until the more contemporary Paradigm HF trial, which showed that ARNI was more favorable. However, although like hydralazine isosorbide kind of fell off the map for a while, some post hoc analyses once again brought it into the limelight, showing that the combination of hydralazine isosorbide dinitrate was beneficial, particularly in African American patients, thus prompting the design of the AHEFT trial, which confirmed the benefit of these drugs in combination in an African American patient population with heart failure. So my sorry here, this is blocking it. But one thing to note though is in the AHEF trial, 90% of the people that were enrolled in the trial, which were African Americans with HFrEF and class 2 to 3 symptoms, 90% of them were on ACE inhibitors and angiotensin receptor blockers, and 70% of them were also on beta blockers. So the takeaway here is not that hydralazine isosorbide is a surrogate for these therapies, but rather the benefit is additive, perhaps only in those who are intolerant to RAS inhibition due to maybe renal insufficiency or drug intolerance, and can be thought of more as like an adjunct therapy to reduce morbidity and mortality, but not to replace. And the guidelines reflect that. So it's really meant to be in combination with core therapy or core optimal medical therapy, which might include today ARNI or ACE ARB if ARNI is not possible. And then for folks that are not on ACE ARB ARNI, kind of garners a to be indication, maybe a little bit more of an unknown, but kind of a reasonable thought process to think of it as perhaps like a surrogate. So we just kind of talked about isosorbide dinitrate, which is an oral nitrate, and nitrates have been around for a long time, have been an interest in heart failure. So targeting the nitric oxide soluble guanylene cyclase CGMP signaling with organic nitrates will directly stimulate soluble guanylene cyclase, which has been used in heart failure for many years. Unfortunately, oral nitrates or IV nitrates with like glyceritide, like we spoke about, is associated with side effects, headache, dizziness, hypotension, and also the development of tolerance with nitrates is common over long-term use. So other drugs targeting this pathway have included like phosphodiesterase inhibitors or PDE5 inhibitors, which limit the degradation of cyclic GMP, but require the availability are kind of dependent on the existence of nitric oxide, which is actually decreased in patients with heart failure. Due to endothelial dysfunction, there's a decreased availability of nitric oxide to begin with, and the presence of, partially due to the presence of reactive oxidative species. There's also desensitization of soluble guanylate cyclase to nitric oxide. There's a relative deficiency of soluble guanylate cyclase and reduced cyclic GMP signaling, all contributing to heart failure disease progression. So a novel therapy, vericiguat, is a soluble guanylate cyclase stimulator that works by enhancing cyclic GMP pathway by binding to a binding site on soluble guanylate cyclase independent of the nitric oxide binding site. And by doing so, it actually increases the sensitivity of soluble guanylate cyclase to whatever existing levels of endogenous nitric oxide are around, and ultimately catalyzing the conversion of GTP to cyclic GMP, which acts as a secondary messenger and helps maintain normal vascular tone, which is important in heart failure because these patients tend to be very vasoconstricted, which has detrimental effect on myocardial oxygen consumption and contractility. Um, so the Victoria trial enrolled over 5,000 patients with heart failure with reduced ejection fraction, with an EF less than 45%, class 2 to 4 symptoms, with a recent hospitalization for heart failure in the past 6 months. Again, notably, 60% of the patients were already on ACE, ARB, ARNI, beta blocker, mineralocorticoid receptor antagonist. So this is kind of done in that background, but the patients were randomized 1-to-1 in a double-blind style to vericiguat versus placebo. And while vericiguat achieved its primary composite endpoint of cardiovascular death or first heart failure hospitalization compared to placebo, it didn't do so with like particularly compelling statistics. With only a 3% absolute risk reduction in the composite endpoint, which was largely actually driven by about a 2% reduction in heart failure hospitalization rather than much weight in the mortality benefit. So are we using vericiguat commonly in practice? Like personally, me, no. I think like amongst the folks in our group, similarly, like not so much. But when might you consider vericiguat? Maybe if somebody is already on maximal four-pillar GDMT and yet they continue to be symptomatic and they continue to be hospitalized, because remember the Victoria trial pre-specified a recent hospitalization for heart failure. um, then yeah, maybe think about vericiguat as like an adjunct therapy, and maybe it might reduce that risk of heart failure hospitalization. Um, so something to kind of think about, but not something that has garnered particularly strong support, and therefore the guidelines only give it a 2B indication for reduction in that outcome. What about diuretics? Like, is there really evidence for one or another, or is it more of like a choose your poison? So the Transform HF trial was an open label randomized trial, about 2,800 patients with heart failure in the US, randomized 1-to-1 to either torsemide or furosemide, and with investigators selecting the dose. Sadly, the study found no significant difference in torsemide and furosemide in all-cause mortality, hospitalization, or quality of life by Kansas City questionnaire in heart failure amongst patients that were hospitalized for heart failure. So I will say that the study was limited by higher than expected rates of noncompliance and crossover, but sub-analysis of on-treatment analysis at discharge and at 30 days again confirmed the primary results. Unfortunately, even those that stayed on track and followed their prescribed diuretic, those patients, despite their adherence, did not have any improvement in mortality, hospitalization, or quality of life. So for me, oral diuretics really are kind of like provider preference. I personally just choose whatever works, and decision should not be kind of clouded by thought that it will one offers a better mortality benefit or another. Yes, there's pharmacokinetics and bioavailability, which you should definitely bear in mind with improvement with bumetanide and torsemide as opposed to furosemide. But if patients are doing fine on furosemide, then that's okay, and as long as you're kind of keeping a close eye on them. The loop diuretics that we're just talking about, work in the loop of Henle, but and they do so by blocking the reabsorption of sodium, potassium, and chloride. However, there is potential that later in the nephron, there's once again reabsorption of sodium in the distal convoluted tubule, which then kind of negates the natriuresis effect that you're trying to achieve with a loop diuretic. So perhaps sequential blockade of the nephron may help people achieve better diuretic responsiveness. So the chlorotic trial was a prospective randomized trial, placebo-controlled, in which patients hospitalized with acute heart failure were randomized 1-to-1 to receive hydrochlorothiazide versus placebo. in combination with their existing furosemide loop diuresis. And the treatment group achieved more significant changes in weight from baseline and improved dose responsiveness to the diuretics that they were getting by 96 hours. However, notably at the expense of impaired renal function and increased frequency of hypokalemia, although none of these hypokalemia events resulted in any significant difference in serious adverse events. So no like hypokalemia related deaths necessarily. So it'll help you get there faster for sure. Maybe your kidney function will be a little bit worse off for it. However, there may be some value in what is kind of perceived as over-diuresis. And maybe there is some value in hemoconcentrating. So when looking at two groups of people, those that end up hemoconcentrated, which is based on a delta in their hematocrit or change in their hematocrit, albumin, total protein, or two of three of these, those that achieve hemoconcentration actually have an improved cumulative survival at a 6-month time. So you're better off maybe taking on that acute insult in renal function in favor of a long-term survival benefit and also decreased risk of rehospitalization due to underdiuresis. So in guidelines, it kind of reflects like what we said. It's a little bit of choose your poison. People that are decompensated opt for IV diuretics to help them achieve euvolemia faster. But there is no particular weight in one diuretic over another. So what about cardio memes, not cardio memes? But I share a meme here that I made and I think is pretty good. So I checked the JVP. Be honest. I checked the S3. Be honest. Okay, I just checked their cardio memes because nobody looks at S3 or nobody looks at JVP and nobody auscultates hearts anymore. We just look at echoes. So we just look at the cardio memes and it tells us exactly what we want to know. So what is cardio memes? CardioMEMS is a implantable pulmonary artery pressure sensor.
The procedure is straightforward. A cath is placed in the pulmonary artery to determine baseline hemodynamics and, along with a selected
are you guys hearing the audio?
To confirm the target
Try muting it.
vessel. The pressure delivery system is advanced over a guide wire to the identified target implant site. Once in position, the sensor is released from the delivery cable. And it's not in all loops.
I'm not sure if you guys can hear it, but I hear it.
We can hear it.
You guys necessarily hear it. But this is the pulmonary artery pressure sensor, and it's done through venous access. A 12 French sheath is used through femoral access. It can be done through IJ access as well. That's introduced kind of like a Swan-Ganz catheter. And actually, to start off the procedure, we perform a PA angiogram. And delineate the pulmonary artery anatomy. And thereafter can, over a wire, introduce this pulmonary artery pressure sensor that kind of looks like that little infinity loop. And it, sorry, in your hands will, be about the size of like a quarter in length, but very thin profile. And the majority of the length there is those very soft, distensible wires that really anchor it in place. And as you saw in the animation there, kind of fibrose and secured in position. And does it embolize? No, we park it in kind of right before a bifurcation of pulmonary artery branch vessels. And the vessel needs to be large enough to accommodate it. And by parking it right at the fork, it will not kind of migrate distally. So there have been a number of clinical trials looking at the pulmonary artery pressure sensors. The Champion trial was the first one, a randomized trial of about 550 patients with class 3 heart failure symptoms on optimal medical therapy, which demonstrated a 28% reduction in heart failure hospitalizations at 6 months and a 37% reduction over a 50-month period. But what's more compelling is that once the control groups gained access to the pressure data, because this again was like a randomized trial of the use of the device. Everybody got the device, but only 50% of people had hemodynamic guided diuresis. But once the control group crossed over and gained access to their pressure data, their hospitalization rates similarly decreased by 48% compared to their prior control period. And there was a trend towards a mortality benefit, but unfortunately, it just barely missed meeting clinical significance. A limitation of the Champion trial was that the study was non-blinded with differential contact between study personnel in the treatment arm. So there was some concern for bias. Also, the Champion trial kind of evaluated a sicker patient population with New York Heart Association class 3 symptoms. So to kind of address these two pitfalls, the GUIDE-HF trial was a multi-center, single-blinded randomized trial. And while the study did not meet its primary composite endpoint of mortality and total heart failure hospitalization, the study was actually impacted heavily by the COVID-19 pandemic, which took place kind of in the middle of the study enrollment and follow-up period. So a pre-COVID analysis showed that the impact of the hemodynamic guided monitoring and heart failure management with CardioMEMS actually did result in a 20% reduction in heart failure hospitalization, and that the benefit was unfortunately lost during that COVID-19 pandemic period because neither the treatment arm nor the control arm were going to the hospital to seek hospitalization or seeking care at all. But in the pre-COVID period, there was a significant difference here in the hazard ratio of the primary endpoint of mortality and heart failure hospitalization, and then in the secondary endpoint of heart failure hospitalization. So kind of putting it together, there was a nice meta-analysis of the three major randomized trials of hemodynamic guided heart failure management using an implantable device. That device being the CardioMEMS in the Champion trial and the GUIDE-HF trial, and then in the laptop HF trial, which was separately a different direct implanted left atrial pressure sensor, which is not currently on the market. But a total of 1,350 patients were included, and the data finally demonstrated that management using an implantable hemodynamic monitoring significantly reduced both heart failure hospitalizations shown above and mortality. Interestingly, there's the divergence of mortality benefit happens around that 1 year mark. So it's not immediate, but perhaps by keeping people under better fluid control, avoiding rehospitalization, that they over time will manifest the mortality benefit we are hoping for. And the guidelines reflect that with a 2B indication for patients in the management of heart failure on optimal medical therapy with persistent symptoms and perhaps hospitalization for the use of a PA pressure sensor. And the way we kind of think about it in practice is people that are really difficult to interpret their volume status based on examination or have very brittle heart failure. We might think about implanting a pulmonary artery pressure sensor, the CardioMEMS, to try to stay ahead of it as much as possible. And by remotely monitoring it, we can be in communication with them more frequently and prevent these exacerbations. And on the last couple slides here, I appreciate you guys' time. So ivabradine, what is ivabradine? I've probably heard of it, but it's a medication that blocks the hyperpolarization activated nucleotide gated channel, which is responsible in the SA node for being like our cardiac pacemaker current. And that current is called the funny current. It's a sodium channel based current. And the mechanism selectively reduces the heart rate by slowing the depolarization process that happens on a cyclic basis. And by slowing the diastolic depolarization, you actually reduce the R to R interval and you slow the heart rate over time without the negative inotropic effects of a beta blocker or some sort of AV nodal blocker. So the SHIFT trial was a randomized double-blind trial of 6,500 patients with HFrEF EF below 35%, class 2 to 3 symptoms, with sinus rhythm with a resting heart rate above 70 on maximally tolerated beta blockade. And those patients were randomized to ivabradine versus placebo. And ivabradine helped people achieve an average 15 point reduction in their resting heart rate from an average baseline of about 80 in the population. And the trial showed an 18% relative risk reduction in the primary composite endpoint, cardiovascular death or heart failure hospitalization. Although the benefit was primarily driven by the heart failure hospitalization component and less so by the mortality. And so the way I typically kind of think about using ivabradine, and I do use ivabradine, is just as it kind of delineated in the inclusion criteria here, patients that are on maximally tolerated or max dose beta blocker and their resting heart rate is still above 70, I'll tag on ivabradine as like an adjunct therapy as well. Or, and I have this sometimes in like end-stage renal patients that have prohibitive hypotension, intolerant of beta blocker. I might consider the use of ivabradine in lieu of a beta blocker to try to get their resting heart rate down to decrease their overall myocardial oxygen demand. You don't derive the same like pleiotropic effects that a beta blocker does in terms of preventing fibrosis and blockade of the sympathetic nervous system that we were talking about before, but at least we're kind of decreasing the myocardial oxygen demand, and maybe that will lessen fibrosis over time. And what about iron? There's been anemia and iron deficiency is common in the heart failure population and is associated with severe symptoms, impaired quality of life, decrease in exercise capacity, and increased heart failure hospitalization and mortality. And iron deficiency being defined as a ferritin less than 100 or a ferritin between 100 and 300 together with a transferrin saturation or iron saturation less than 20%. So there's been many studies looking at iron replacement therapy with IV iron and its effects have shown improvement in functional capacity, quality of life. However, once again, the COVID-19 pandemic kind of tainted a number of these analyses in the hard outcomes of heart failure hospitalization and cardiovascular death. So a meta-analysis performed actually earlier this year of this 6 landmark IV iron trials versus placebo showed in fact, lower rates of the composite endpoint of recurrent hospitalization and cardiovascular mortality at 12 months, with effects sustained through completion of the length of follow-up. So, although kind of each of the individual trials that we know of, affirm, confirm, the Ironman trial did not meet that hard endpoint. Taken together, they do have a significant reduction in that hazard ratio for that primary composite outcome. So always think about assessing iron deficiency in patients each time they're actually hospitalized with decompensated heart failure and see if there is a role, if they meet criteria for IV iron repletion. Yeah, again, this guideline published in 2022 before this meta-analysis kind of contemporary in 2025. So we might see that IV iron in future iterations of the guidelines maybe garners a little bit more support, although it is a meta-analysis at the end of the day and not a randomized trial that met the hard endpoint. And now, we've shown kind of the long chronology of heart failure going back to like the 1980s. Now we're in the digital era, pun intended, with the DIG trial being a trial I think we maybe are all familiar with. I'm sorry, my diagram here also blocked the figures, but the DIG trial from 1997 was the first landmark trial supporting the use of digoxin in heart failure, and a randomized double-blind placebo trial. Heart failure EF less than 45%, demonstrated that digoxin unfortunately had no effect on all-cause mortality, but significantly reduced heart failure hospitalizations, which is sort of this bottom figure here. But the top figure, the two lines were kind of in parity, mirroring one another with no reduction in mortality. And low serum concentrations of 0.5 to 0.9 and were associated with improved outcomes, but high concentrations were associated with increased mortality, ventricular arrhythmias, et cetera. All that said, the DID trial, like we said, 1997, was conducted before Google was even founded, which was in 1998, and before the advent of the contemporary four-pillar medical therapy that we know to be of such high value today. So a more contemporary iteration of this trial, I'm sorry, this is frustrating me now. Let me move this out of the way. Was the DIGIT-HF trial, which is a German trial. Holy, sorry, guys. A German trial of a novel form of cardiac glycoside, which is digitalis. So unfortunately not available in the US. However, I'm sorry, guys. Yeah. Okay. Okay. Sorry. Unfortunately not available in the US, but this was a double-blind placebo-controlled trial of 1,200 patients, EF less than 40, class 3 to 4 symptoms, randomized to digitalis versus placebo. And it actually did meet the primary composite endpoint of death from any death from any cause or first heart failure hospitalization for worsening heart failure symptoms. With not a huge difference, but about like a 5% reduction in that primary composite outcome in the digitoxin cohort versus the placebo. So unfortunately, again, this is like a novel trial, not reflected in the 2022 guidelines. Also, this drug is not yet available in the United States. However, we might see that digoxin or digitalis in this form may make its way kind of back to us in the near future. And lastly, kind of final word here. So what do we do with heart failure therapies when people have recovered? Or better yet, oh man, what do we do? Or better yet, is recovery even like the right term, or is it just improvement? Is it just kind of fleeting? So the TREAD-HF trial put this to test, and I'm sorry here, I'll exit in a minute. But what this study was a small study, only 50 patients, a study in the UK, taking patients that had recovered dilated cardiomyopathy, now asymptomatic, with an EF that was previously less than 40, now greater than 50, with normalized left ventricular end diastolic volume and an NT-proBNP that was now less than 250. And patients were randomized 1-to-1 in a phased withdrawal versus continuation of therapy, and followed by a single arm crossover at the end of the study phase, where the continuation group also underwent withdrawal. And the results here, although small in number, were impressive, like very impressive. So relapse was identified, was defined by one of four criteria: either a reduction in ejection fraction by a magnitude more than 10% to now less than 50% measurement, an increase in left ventricular end diastolic volume greater than 10, a twofold increase in NT-proBNP to greater than 400, or clinical evidence of heart failure. 11 of 25 patients in the withdrawal arm relapsed compared to 0 in the continuation group. That's 44% of people in the withdrawal arm relapsed. And then during the crossover period, people that were initially in the continuation group that then underwent withdrawal, 9 of those 25 patients who later withdrew in the crossover relapsed. So an extended follow-up at 6 years revealed that 65% of patients ultimately relapsed who had their medications withdrawn. So the risk remains substantial even after restarting the medications at lower doses after the trial. So, they encountered relapse and they're like, oh no, I want to get back on medical therapy, maybe at lower doses or something like that. And the risk remained thereafter. So based on this study, and again, albeit like a small study, only 50 something patients, um, the findings are pretty compelling and advising us to stay on guideline-directed medical therapies kind of indefinitely in patients with improved ejection fraction. That's why we don't really call it recovered ejection fraction, because you're not out of the woods, clearly, as this study shows. And until more robust predictors of safe withdrawal are identified, treatment discontinuation is not recommended, as is shown in the guidelines here. So I'm sorry for going over time here. A few tidbits that I wanted to share. One, don't stop GDMT just for acute decompensation of heart failure or a mild decrease in renal function. Like we saw, hemoconcentration actually might predict better outcomes in patients. So we should strive to really dry people out. And a simple kind of warm and wet decompensation doesn't mean you got to stop medical therapy. That being said, if patients are stage D heart failure with marginal output, like they're cold on exam, then maybe avoid a beta blocker and avoid the negative inotropic effects of a beta blocker. If they're on it, then maybe that's the cause of their decompensation. They just don't have the bandwidth to tolerate that negative inotropic effect. I personally don't initiate midodrine to accommodate the introduction of GDMT or uptitration of GDMT for that matter in folks that have chronic hypotension. I would rather them be on neither. Midodrine has strong data showing predictor of poor outcomes in heart failure population. So I would rather them be on neither rather than just introduce one but have to chase it with midodrine. And that I think that is a better practice than doing this kind of chasing sort of approach. And GDMT in end-stage renal disease, kind of a data-free zone. I kind of alluded to earlier. I personally, and I think a lot of my partners would agree, I get people with end-stage renal on medical therapy, even ARNI, even ACE inhibitor, ARB, mineralocorticoid receptor antagonists. I just pay particularly close attention to their potassium history and trend and their blood pressures. But if they don't frequently encounter hyperkalemia and they're not chronically hypotensive, it's okay. Whether there's data to support it, unknown. But I'm hoping for kind of the pleiotropic effects of some of these medications to take form in an end-stage renal patient phenotype. And don't freak out if people's blood pressure is low. As long as the patient's feeling well, that's the most important thing. So I tell my patients, like, if their blood pressure is like in the high 80s, low 90s, and they're feeling fine, that's okay. That's the most important thing. Yes, there's ultimately like a tipping point. Like, I don't want their blood pressure like in the 70s or something like that. But it's kind of case by case. You see where they're kind of starting out with. If they've started out with a blood pressure of 150, maybe I don't want to drive them down to like 80. But if they started out with like in the 100s, one teens, and now they're like in the high 80s, it's probably fine, especially if they're feeling fine. And if you're nervous about it, you can even think about like half doses of ARNI, like a 12, 13. You tell them to take half a pill twice a day. And always kind of keeping in mind, striving to escalate therapy as tolerated. And I usually kind of see SPP greater than 100 as opportunity. I kind of see it as a glass half full. In that strong HF trial, they actually rapidly escalated with SPP target threshold above 95. And lastly, don't de-escalate medical therapy, as the TREAD-HF trial kind of showed us. It will be a high risk for relapse for your patients. So last thing here, just a MOC question. A 72-year-old man with ischemic cardiomyopathy, EF 25% is admitted for decompensation, lower extremity edema, dyspnea. He's diuresed aggressively. He's now euvolemic. His blood pressure is 102/64, heart rate 78. His baseline creatinine is 1.4. It's a little bit up to 1.6. His K is 4.7. He's on guideline medical therapy, which includes metopsuccinate 100 and losartan 50. And we want to optimize his medication before discharge. Which of the following medication changes provides the strongest evidence-based mortality and morbidity benefit? can be initiated safely during this hospitalization and is most appropriate based on the current clinical status. So one, would you switch the losartan to Entresto and simultaneously start hydralazine isosorbitol nitrate together to maximize afterload reduction? Two, would you add an SGLT2 inhibitor such as dapagliflozin or Farxiga, despite his borderline blood pressure and mild AKI? Three, increase the beta blocker to maximum tolerated level before discharge. Or four, hold any medication adjustment until outpatient follow-up because the renal function is not fully stable. So I'll give you kind of a minute to stare at this. So maybe kind of walking through it. Option A, switching to losartan and or switching to Entresto and adding hydral iserdil. While the ARNI initiation is appropriate, I would not necessarily throw on the hydral iserdil on board as well. Again, remember that the hydral iserdil is really just an adjunct. So I would first prioritize getting them on 4-pillar therapy first, before adding on some of these little adjunct options that you have. And unless they are intolerant of ACE, ARB, ARNI, I would not think about hydral iserdil up front. And again, remember that the data for that is most robust in an African American population with persistent symptoms despite being on appropriate GDMT. And adding the iserdil hydral with the ARNI, you're going to put the patient probably at increased risk of symptomatic hypotension if they're only starting with a blood pressure of 102. What about option C, increasing the beta blocker dose? So he's already on 100 metoprolol succinate. His heart rate is 78. It's not perfect, but he's on a nice dose of the beta blocker, and he was just hospitalized for a decompensated heart failure. So remember, we talked about beta blockers. I kind of take it a little bit slower. I'm not rapidly escalating like some of the other medications because of that kind of negative inotropic effect. So I would kind of wait till they get fully out of the decompensated window and then maybe pay more attention to fine tuning the heart rate. So maybe on that first outpatient visit, then I'm doubling their metoprolol to 100 BID. And try to get their resting heart rate below 70. Option D, hold any medication adjustments. That pains me as a heart failure cardiologist to see that. And like that's definitely not the answer. The mild AKI, yeah, he's got a little AKI, but it's not prohibitive. Like we kind of talked about some of the thresholds with MRA and SGLT2 inhibitor. So the answer here is B. I would prioritize getting on all 4 of these pillars of therapy, and then kind of fine tuning things to more true optimal therapy thereafterwards. So he's already on an ARB, he's on a beta blocker, and I would work on trying to get him on an SGLT2 inhibitor first. Again, I think that the impact on renal function or causing like acute insult to injury is not significant with SGLT2 inhibitors, and his eGFR is going to be above the 30 mark here. I think that would be the right move in this situation. Also, the SGLT2 inhibitor, not significant impact on the blood pressure or hemodynamic effect. So he'll for sure safely tolerate it in terms of vital signs. And maybe the MRA I would defer until outpatient follow-up. Maybe their kidneys have cooled off a little bit. They're closer to baseline of 1.4. And then at that first outpatient visit, I would get them on a spironolactone perhaps. So that's how I might approach this clinical scenario. So that is all I got. I thank everybody. I'm sorry it took probably an additional 15 to 20 minutes of your time. But I appreciate everyone's attention. I'm happy to answer any questions.